So what we're going to do now, it's going to be like like at an auction, where you make a little signal to the auctioneer that you want to make a bid. If you could just do that, and I'll make signals to you as to when, I'm going to come around to you and try to. And so I'll throw it out. Who has our first question? Let me run down there. We'll go here first, there second, and then third. And I'll hold the mic.
All right, thank you. Two questions that I have. One is the results that you had on the case studies. If you were diligent about getting a physical every year or so, is that a typical blood test that those results would be? Or if you have smoldering myeloma, do you have to ask for a specific additional blood test?
Sorry. So lots of folks come to me after being diagnosed, either with smoldering or with active myeloma, and say, I don't understand. I was seeing my primary doctor. I was getting blood work on a regular basis. How could this be missed? And the answer is this is still a fairly narrow family of diseases that we need to specifically look for. We need to ask the lab to do very specific tests to look for specific proteins. Once you have that diagnosis, if you come and see a hematologist or an oncologist, you should get those tests. You shouldn't have to, ask them to do it. If you're following with a primary doctor who may not have as much experience in this, then yes, it does. It's something that you need to make sure, because it wouldn't be part of standard, regular physical blood work. You would have to ask for protein electrophoresis, serum immunofixation, and free light chains or kappa lambda measurements. And those are done in the world of the specialty, where we know what we're looking for and we want to monitor it closely. We do those routinely for everybody, but others might not so much.
Okay, and then my next question is again for you, Dr. Butler. You had Revlimid seems to be a first line of defense with myeloma, and you made a comment that Revlimid also has some side effects that could increase chances of other types of cancer. Is that correct?
This is something we don't like to talk about, but I also never like to, I like to be on the table. It is a signal, and if you look at a large enough group of people who have had Revlimid for a long enough period of time, the risk of developing cancers goes up a little bit. And it's a very small signal, and as long as we use the drug the way it's meant to be used, the benefits greatly outweigh the risks. So it's not a reason not to go on Revlimid. The risk is really small, and you have to have a big study to see it. But it also just a reminder that these tools, these weapons that we use against cancers, they're serious drugs, and they're heavy decisions, and we don't take them lightly. There's always some risk that comes with what we do, and we're just always trying to balance that and keep it on the side of benefit outweighing it.
I think it's important to highlight that there are real side effects of any drug that we might administer in any setting, smoldering, newly diagnosed, relapse refractory. I would probably also just make the point that risk of secondary malignancies or secondary cancers with Revlimid therapies is probably most pronounced in patients who have undergone prior autologous stem cell transplant, prior high-dose chemotherapy and autologous stem cell transplant. So that's probably where the largest signal is seen, and that's been seen in the studies as well. And I think an area of research that's currently going on in the field is how can we potentially predict, which patients may be at higher risk for developing secondary cancers. And there's, this whole field basically called clonal hematopoiesis indeterminate potential, basically where lenalidomide might induce some changes in some of the very, very precursor, cells that might lead to cancer that, could potentially, provide some increase or better risk stratification in these cases. But I think, again, the most data, I think, is particularly in patients who've undergone transplant is where you see that secondary malignancy risk.
Can I say one thing? So I think the other thing is to remember, like, we are, you know, I don't know about these, like, I really primarily see myeloma, and so, you know, the cancers you're going to get are not myeloma, right? And so I think that for certain things like skin cancers, colon cancers, breast cancer, those types of things, you know, that is still things you can screen for. You still need to do that. So in the post-transplant period, you're on maintenance. I think you have to sort of check the box of saying, look, are we screening patients like that we would normally screen anyone for, colonoscopies, mammograms, all that. Those, you know, seeing a dermatologist perhaps, like I think all of those are still really important things to keep in mind. But, you know, for me as a myeloma doc, you come, you have myeloma, that's what I'm focused on, but you have to remember those things as well. And oftentimes those things are best served by a primary care provider who does cancer prevention and early detection.
Just to follow on that, Dr. Robert Kyle, who's arguably the founding father of myeloma science today, who just celebrated his 95th birthday last week. In all of his patient talks, he makes the point there is no such thing as a completely safe drug. And he always points to the example that there are a certain number of people every year around the world who die because of allergic reactions to aspirin. So there is no such thing as a safe drug.
Yes, I keep hearing of people. A friend of mine had a terrible hip fracture, and when he got diagnosed with multiple myeloma, and was like 75% with the biopsy. And that last woman there, it was a similar thing. Now, in my case, my primary care physician noticed something in my standard blood test, and he sent me to a hematologist. And I had no symptoms, no kidney problems or anything. So I'm wondering if there's something they need to add to the blood test that you get annually, or did this guy see something that other doctors ought to notice?
Thank you very much for that question. So it is often one of the first questions that we get asked when our patients come to clinic is that, you know, I'd been going for regular checkups. I've been seeing my PCP regularly for the last many years, right? And how is it that this was not found? Or I was complaining of back pain for a year and a half, and how is it that this wasn't picked up? Yeah, unfortunately, this is more often the rule than anything else. 99.999 times out of 100, most people that show up with back pain to their primary care physician's office show up with, you know, are found to have because they moved their TV the wrong way or picked up their grandkids when they shouldn't have, things of that sort. So there are lots of pros and cons to routinely adding things to screen people to see, you know, what if they might have MGUS, which is the precursor to myeloma, if that might have myeloma. The pro is that you might potentially find something earlier. The con is that you might find something you didn't want to find and that you go messing with, and then all you do is you break something that didn't need to be broken. You did try to fix something that wasn't broken in the first place. And there are other things to be aware of over here. So there's this very nice large study that is coming out of Iceland, and it's called Iceland Stops, Treats or Prevents Multiple Myeloma. And what the people in Iceland did was that they took everyone who, when they started the study, was over the age of 40, born after 1976, and came up with about 80,000 people. And they said, look, what we're going to do is we're going to try and see what happens if we divide people into 3 groups. We look to see if all of the people who are on this study have MGUS, and then we'll see if we leave them alone, what happens. That's one group. If we watch them like you're supposed to watch them per standard guidelines for MGUS, which is the precursor to myeloma, or what do we do if we have aggressive follow-up? And, you know, so Iceland's a very homogeneous population, and there are a lot of interesting data that are coming out of there. But so far, they haven't made a slam dunk recommendation that everybody should get screened for MGUS. And I think that that bar will also have to be very high. You know, there's another study that's going on, which Hopkins is a partner with Harvard and so on. It's called the PROMISE study, which some of you may be aware of. And that looks at people who are at higher risk of getting myeloma, perhaps, especially people who might be of African American descent, and people who have first degree relatives who have myeloma. And a lot of times, again, people come to my clinic and they're like, I have myeloma. What does this mean for my son or my daughter or my siblings? The first thing I tell them is that most people that come to my clinic don't have anyone around them that has myeloma. the risk of any one individual getting myeloma is pretty minuscule. And even 2 to 4 times minuscule is still pretty minuscule. But it makes sense to do a study like this. All right, fine. They use very special tests to try and see if these patients who are at higher risk of getting myeloma might have these abnormal proteins that we find in M spike and light chains and so on. The test is called mass spectrometry. All right, that's great. But when you look at the figures, what they found is that in people over the age of 80, in this particular group, more than 60% have some form of abnormal protein. And when I hear that, in my mind's eye, I see a lot of my 80-year-old friends lining up outside a clinic to get a bone marrow biopsy looking all sad. I'm like, so if we go looking for things and we find things, then we sit there wondering what to do. There are studies actually looking at patients who have MGUS or smoldering myeloma, MGUS in particular, that shows that, look, when you find something that nobody wanted to find, then it really messes with someone's life and it messes with their head. So before we really go and upset an apple cart, as it were, I think we really need data in multiple different settings to see if that might make a difference. Right now, as such, I don't see that everyone, like me walking into my PCP's office, right? I walked into my doctor's office and 6 months ago, she told me I needed to get on cholesterol medication. I've been dodging that bullet so far. But if she told me you need to get tested for MGUS, I would have just run in the other direction. So before we do these things, we really have to have data that backs up that, look, I'm actually going to make a difference. I'm going to help more people than I harm. And I really don't want to harm anyone at all. But these are excellent questions to consider. Thank you.
And the other thing is, just like there are no perfect safe drugs, there are no perfect safe tests, right? So all tests can be erroneously positive, they can be erroneously negative, they miss stuff that's there or they see stuff that's not there. And so even scans can do that, blood work can do that. And so I think you just have to keep in mind, like, if we went and, did HIV testing on all of us, most of us don't have HIV, but there are some people where the test would be positive, right? And then you need to do other things. And so no test is really perfect. And so when you apply them to large populations, you're going to find a lot of stuff that's probably not real. Like, you'll find something, you might catch stuff early, but not. And the other thing is there are a lot of conditions where you find them and you don't know what's going to happen. So MGUS is one. The other is, there's some, I don't even know if this is true. There's this, what I have heard is that, like, if you check every single male who's older who passes away of something, you're going to find some evidence of prostate cancer in them, right? So if you go looking, right, you find it, then are you going to do a prostatectomy? Are you going to do radiation? Do you really need to do those things? So it's just, there's part of us, like, we are not perfect beings, and so there's stuff that's on the edges that doesn't look normal, but whether or not that's going to be impactful, I think it's difficult. And what Abbas says, I think, is really powerful, which is, you tell someone, look, you have this, but we don't know what it means, and we think it's probably going to be okay. We feel okay about that, but the person who leaves the office then and says, oh my God, I have no idea what to do with this, they don't know what to do with it. Like, what is going on here? I think that is a burden that we hopefully don't put on a lot of individuals. So I would just sort of put it down.
Can I just make one quick follow-up to that? I agree with Bill very much, but I am only grabbing the mic because of the example that he gave. Last week, or last Tuesday, in fact, which was, I guess, a busy day, I actually saw somebody who was referred to me with HIV, and they had had an infection that you don't typically get. And so in the course of that workup, they found HIV. And people, when they get infections, sometimes proteins can go up. So they were like, well, this person is HIV and the proteins are a bit high. Let me go looking for MGUS. So now they found the HIV and now they found the MGUS. And she was sent to my clinic crying with, do I have myeloma? Do I have cancer? And I was like, well, not only do you not have myeloma, but you have MGUS, which is minuscule precursor to myeloma. I don't really think you have that either. But also, you don't actually have HIV because this was a false positive and your very last HIV test was a negative. So every interaction with the system can lead to a cascade of events, and you have to be very careful before we, do interventions that are just not in someone's best interest. Thank you.
First of all, thank you very much for spending your Saturdays with us and giving us the very intriguing lectures that you've given. It's very, very interesting. I think I wrote 5 questions down, but I'll ask my easiest that I think's the easiest. So when you have your initial bone marrow and you get your fish results determining if you're high risk or not, does that change? Do you always stay high risk forever? And my second part of that question would be, with new things coming out, should you refer back to the original fish and just make sure you're not now considered high risk? Or how do you feel about the high risk, low risk risk?
So, no, thank you. That's a very good question. It took me years to get my head wrapped around this high risk, low risk business, let alone for people who are seeing this for the first time. And it sort of, cancers in general and myeloma in particular, these are very heterogeneous diseases, which means the cancer cells change over time. And depending on how patients are doing, depending on the state of their immune system, depending on mutations that they may acquire or may not acquire, depending on the treatment that they receive. In general, when I see a person with a specific high-risk feature at diagnosis, then I always treat them as having had high-risk disease. And if I don't find it later, then I don't necessarily assume that that's entirely gone, right? Especially for things like deletion 17p and translocation 14/16. These are high-risk features. I don't assume that these are ever gone, even if I don't find them later on. But you do find heterogeneity in the sense that there are parts and bits and pieces of the same patient that may have more higher risk features and others that are not. For instance, I have a gentleman who is in his early to mid 60s, and he was referred to me with multiple myeloma, and he had had a big lump in his back. And when he had surgery to take out the lump, and they did this biopsy and looked at the tissue, 99% of the cells in there had a deletion of 17p, which is what we consider to be a high-risk feature. And the reason 17p is a high-risk feature is because on that part of chromosome 17 is a gene that's like a self-destruct button inside the cell, right? The reason 17p is high risk is because when cells go bad, whether it's because they've been invaded by bugs or they become cancerous, they lose the plot, so they flip the self-destruct button, just like ships in alien movies, right? But things go bad, you flip the self-destruct button. That self-destruct button is on the part of chromosome number 17 known as 17p. So when you say that someone has a deletion 17p, what you're saying is that the self-destruct button is missing. So now when you try and kill that cancer cell, you can't get it to flip the switch. So it's a tougher cancer to kill. But this person had this mass in the back, and 99% of those cells had this high-risk feature. But the bone marrow biopsy, which still showed 50% plasma cells, did not have that high-risk feature. So, but I don't treat that person as someone who has standard risk disease. Although I realized that the cells in the back probably were more stranger, worse off than the cells in the bone marrow. But I treat him as someone who has high-risk disease. We try and treat to a deep response as we can, within reason. So he's had chemo, he had radiation to the back, he's had transplant. But I'm always mindful of the fact that even though the bone marrow did not show high-risk features, this whole area in the back did, and I always continue that way. And that's generally how I approach things. I do, whenever there's a reason to get a bone marrow biopsy, then especially if something has changed, there's more disease, or there's a new lump somewhere, or something concerning, I try and get another fish panel to see what might have changed. Thank you.
Yeah, I think one thing to remember is that between high risk and low risk is that it's risk, right? So just because you have something doesn't determine that you're gonna have that. You have a higher chance of having more aggressive disease or a lower chance, right? But it doesn't guarantee you're gonna have something that's very aggressive, or it's not going to guarantee if you have low risk cytogenetics and 11-14, something like that, that everything is going to go smooth sailing and you're not going to have to worry, right? So it's a game of chance here, right? And so for us, we're not going to ever sit down, I don't think, and say, you have this, we're going to do this, and I guarantee you that this is going to happen, right? We just can't, because people are people and things are different. And so I think that you just have to understand that risk gives you a better or less chance of something, but doesn't necessarily say, well, this is what's going to happen to you. And I think that, to me, that's important because you want to put everything in context. And so things like 17p, right? Just because you see it, if it's in 1 in 100 cells, that may be different than if you see it in all of the cells, for example. Or you have 2 copies of a gene in each cell. So maybe one is missing, but what's happening with the other one? Is the other one mutated? Is the other one also been damaged? Is the other one the same? So I think all of these things kind of matter. I think in general, to me, it's sort of like with high-risk disease, our instinct is to be more aggressive, quote unquote, right? You do a transplant. Sometimes people do more than one transplant. If you have the hankering for that, you do higher amounts of maintenance afterwards. And I think it's all still contextual, because if you don't think the person can tolerate 3 transplants, then they should probably not have 3 transplants just because of that, right? So I think it's all still relative to the patient in general.
Dr. Butler, Lee, have anything to add?
The one thing I really agree with Abbas and Bill's comments, and risk stratification is about risk, and we can try to predict what's going to happen, but we are oftentimes wrong. And I think another concept that's emerging is something called functional high risk. And so sometimes, because the fish may not be absolutely predicted, we have standard risk patients that progress earlier or have earlier relapses. This concept of functional high risk, like if a patient relapses on their initial therapy after a stem cell transplant within 18 months of their diagnosis, that's a high risk disease regardless of what the fish stated. And so I think this is a particularly important patient population that will be looked at in the context of clinical trials, what we can do to potentially, hopefully, change the trajectory of the myeloma disease course. The other thing is that, again, deletion 17p, as mentioned earlier, is considered a high-risk marker. But then, I have a patient actually that's 8 years after their autologous stem cell transplant that had deletion 17p. That's still in complete remission. And I tell the patient, I don't think you have high-risk disease. Biologically, you're not behaving like high-risk disease. So, she's always been labeled as high-risk disease in that sense. And it's not that deletion 17p probably is still there at some, but it just wasn't biologically manifesting itself as a high-risk disease that, led to an early recurrence.
Is there another?
So one other point is that, Matt and I are part of a trial that Hans is actually running. And so it's looking at specifically, one of the screening things you have to do is you have to do a bone marrow in someone who's relapsed, and then you have to go and sequence this self-destruct gene that Abbas was talking about. So, I have had a lot of patients who, we try to get onto that trial. They have this one test done, and to my surprise, there's like a very high number of patients who have this, where I'm just shocked, right? I'm shocked that they now have this thing. And so I think that the idea of and that plays into my mind, because I might say, look, I'm going to give you some form of chemotherapy, but instead of transitioning you to maintenance, I might just keep you on that chemo, right, for as long as possible. So I think that going back, and when things change, I think it's never a bad idea to go back and just get more information. Okay, like if things, I don't think you need a bone marrow like every week, but I think that at times there are pivotal times where having that information, it can be helpful. And you just have to say, look, if I get information, is that going to be useful or not? And I think that's a good trigger for sort of talking to the patient and saying, look, we're going to get a bone marrow because of this, right? It's not just we're going to get a bone marrow because you've relapsed. So I think that's an important thing.
Hi, thank you so much, all of you who are out there looking for a cure. My question today is about CAR T. I think as patients we're pretty excited, and there were some conversations about moving to earlier lines. My question focuses on the idea of durability. Are there promising studies underway that you could brief us on that look at extending the effectiveness of CAR T?
This will be one of the topics this afternoon as well. No, but I just wanted to say we'll go deeper into this.
Yes, this is a great question. This is a topic that people are thinking about a lot. One of the great things about CAR T is it's currently in the current context is a one and done, where you get a single infusion of cells and potentially the cells will exert its effect for many months, hopefully years in some contexts. And so, there's many different factors that may come into play of what can we improve, how can we improve durability response. So, one sort of factor is the health of the T cells originally collected. Because right now we are doing CAR T therapy in late relapse refractory multiple myeloma patients who've had many prior chemotherapies, and their own immune system, their own T cells may not be in the most healthy state. And so there's trials looking at how can we improve or augment the health of the T cells to hopefully lead to better expansion, durability of the T cells when they're after they're infused into the patients. There's other trials looking on the other side, on the back end, of maybe there could be additional drugs maybe given for a fixed duration of time or maybe a longer period of time, which that's also probably a challenge because the attractiveness of CAR T is the one and done, but potentially to augment or increase the length of response. So this is a really important topic. What can we build on the original product? Essentially, it's the first iteration, the first iPhone that's come out, and now we need to find the next versions in the future.
So thank you. Yeah, I'm sure there's going to be a lot of stuff later this afternoon on this. So, CAR T cells in general and CAR T cells for myeloma that have all been around for a while, there's a lot of tinkering and re-engineering and whatnot going on, trying to see if we can get these things to last longer, go on for longer. I think, when I said earlier that when I first met Bill in the beginning or early on when I'd come to Hopkins and Bill was there, and he said, "Look, I want to cure myeloma." I think that's a very worthwhile goal, but cure is a very strong four-letter word to use, willy-nilly, and I feel like people do that all the time. And when the first study of CAR T cells in myeloma was presented by Jim Kokendorfer at the NIH, one of the first questions he was asked was at the ASH meeting was, "Hey, is this a cure for myeloma?" Jim said, "Yes, it is." I think what he really meant to say was this is a path to cure potentially for myeloma. But I think we're still relatively in our infancy when it comes to these things, and there's a lot of engineering that needs to be done, tinkering that needs to be done. There are great stories, and there are other stories that haven't been as successful, and trying to get things where they're uniformly successful is going to take a little bit of time. I bring this up also because, speaking of 17p deletion, right? The first human being to get CAR T cells from myeloma, she was right here from Houston, Texas, and is still getting care. I think last I checked in December 2021 at MD Anderson with one of Dr. Lee's colleagues, she had a 17p deleted myeloma, and she had already been through many lines of treatment. Her initial CAR T cell therapy, she was the first person to get it, did not work at all because it was a very low dose and many things were different about it. But she came back as patient number 15 or 16. She got the CAR T cells and went into remission, and I believe she's had more therapy since. So I think cured may not necessarily be one slam dunk, right? Maybe a combination of things. Maybe it might involve a more functional cure, but I think CAR T cells are very promising. I never want to see the hype get ahead of the data. So I think we should let the data guide us, and they'll get there. They are promising. We're trying to give them to our patients. We're trying to put them on trials. We're trying to move them earlier. But it's always important to follow the data and not as much the hype. And I'm kind of happy lately that the hype seems to have settled down a bit and be going in that direction. Thank you.